So good evening to everybody who's present here, and I really appreciate your presence. I am both honored and humbled to be part of this course, to lead this course where we have all stalwarts, and I feel like a tiny speck, and I intend to learn a lot. We have an interesting program of talks along with a nice keynote lecture, and we hope to make it interactive. I have just one request to all the faculty because we have an 8 minutes keynote lecture also, the AIOS keynote. We will try to wrap up our talks within 10 minutes so that we have some time for discussion. And without much ado, I think I want to start with my talk, and which is more on what is a very hot or a controversial topic. Should we or should we not implant an IOL in an infant? And what does evidence say? This is not what I think or what anybody else thinks. This is what has been mainly published and presented, and what is it today. So I think for us it is very, very relevant because we are one of those countries who has a large burden of pediatric cataract, including infants, although we do see a lot of delayed presentations. And technically we all understand, and we saw those beautiful videos even in the previous session, that we are all getting better. We have better access to technology, techniques, and so much exposure to learning. But functional outcome is something which probably is a lot of it is not in our control, and therefore we are lacking behind, particularly when the child is below 1 year or 6 months when they undergo surgery. So if we are to say why should you implant an IOL in an infant eye, the most important thing is to give early rehabilitation. Even if the child could wear aphakic glasses, the partial visual input that is always present without any refractive correction is something that cannot be given by aphakia. In our country, most of the times contact lens practice is not practical, especially in infants. And obviously we need to correct the refractive errors in a growing eye. But then again, why should we not implant? I think in my mind the most important thing is technical difficulty or surgical difficulty in doing this. If we feel during surgery that the eye is too small or that there was too much manipulation and you could not do an in-the-bag IOL implantation, that is when I think nothing else should matter. All these points should stop, and this is where we should change over our strategy and leave the child aphakic. But these infant eyes, as we know, also have a high risk of exaggerated inflammation, glaucoma, and visual axis obscuration, whatever we may or may not do. And it's very, safe to say that above 2 years of age, and now it's probably even above 1.5 years of age, it is not so much of a question whether or not to implant. It is only in the children below 1 year of age and unilateral cataracts at any age, which pose a problem because that's where you always want to implant an IOL. Secondary IOL also is a part of our strategy, because when you talk of infant cataract surgery, you must, if you are leaving it aphakic, then you have to think of what you will do when a secondary IOL situation arises. And there are many options for that. If we are to do a primary IOL implantation, it is very well agreed in literature that there has to be a posterior capsulectomy, capsulotomy, capsulorhexis. That means posterior capsule management with or without a vitrectomy. And without vitrectomy will only work if you are doing an optic capture in the eye. Now this is one of the landmark studies that has been published recently. Dr. Meenakshi, Dr. Varshini, Dr. Jagatram sir, please join us on the dais. So this is one of the landmark publications, and every year we see at least 1 or 2 articles coming out of this study, the infant aphakia treatment study, which was conducted in the US for children at least, below 7 months of age at the time of surgery, and all of them had unilateral cataracts. Now they have recently studied up to 10 years of follow-up. Randomly, children were allotted to primary aphakia and contact lens or primary IOL. But we need to remember that these were all unilateral cataracts and below 7 months of age when they were operated. What they did find at 10 years follow-up is that the pseudophakia group had 72% of them required a second operation, either for most likely for a visual axis obscuration, but also IOL exchange. And this is something which I think may differ from culture to culture, country to country. In our practices, we don't do so much of IOL exchange, particularly for pediatric pseudophakia so early in their follow-ups. But yes, visual axis obscuration is something which they will need. So they need more surgeries, but the aphakia group eventually needed more secondary IOL operations as they went down the follow-up. So that is something we need to keep in mind, that they will someday need a secondary IOL implantation. So based on this study, they conclude, and they have given a recommendation which has also been followed by the American Academy, that when you are operating a unilateral cataract below 7 months of age, then IOL group performed worse than the aphakic group, and therefore do not implant an IOL. It is very well and it makes sense. But in our scenario, this may not always be the case, because particularly unilateral cataracts, if they do not have a microphthalmos, if they do not have a microcornea, and if there is sufficient surgical experience, it may be a point to implant an IOL. There have been long-term studies from L.V. Prasad regarding unilateral and bilateral cataracts in infants, and they have shown good results also. Now the same study, the infant aphakia treatment study, where they gave free contact lenses, Silsoft contact lenses, and home delivery and home fitting of these lenses was done. And still they found that when you compare the costs, the primary IOL implantation was only about 5% more expensive than aphakia and doing this kind of a contact lens correction. But when you look at contact lens, the overall costs eventually were more than double as compared to putting in an IOL. So obviously that's a factor. So again, like I said, if it is not a microphthalmos, if it is not a microcornea, unilateral cataract, if you can do a good surgery, may warrant a primary IOL implantation. So based on this study and others, the American Academy also has given an implant recommendation. And I think it is fair to say this from the podium, that as a general rule, when a child is below 6 months of age, there is a very high incidence of visual axis obscuration. Their growth is going to be unpredictable, and they are going to need many more secondary interventions. And therefore, you have to be very, very, very careful if you are thinking of an IOL implantation. Another published study, the TAP study, or the toddler aphakia pseudophakia study, it looked at bilateral cataracts between 1 to 7 months of age. Now again, a completely different ball game, and we see more of these bilateral cataracts, so much more. There they found that visual acuity was similar whether you kept the child aphakic or pseudophakic, and obviously IOL does increase the risk of visual axis obscuration. Glaucoma was comparable. So they again recommended that you may not want to do an IOL below 7 months because they need more surgery for VAO. Now this is all very good because all of these both were in the US. Now we look at our population, and our means a lot of part of the world. It's not just India or Asia. This is applicable to a lot of the world. Below 2 years, when there is a bilateral cataract, there is no randomized clinical trial, and we published this few years back, where we looked at 5-year postoperative outcomes, bilateral cataracts below 2 years of age, bilateral aphakia with spectacles and or contact lenses, and bilateral pseudophakia. And this randomized trial was conducted with a very, very rigorous methodology, and we looked at these complications: glaucoma, VAO, inflammation, cell deposits, all defined based on published criteria. What we did find is that the pseudophakic group had more posterior synechia. Well, yes, more visible posterior synechia, because the aphakic might have mid-peripheral synechia, which you do not see unless you do a UBM for these eyes in every case. But when you looked at the glaucoma incidence, it was comparable, and even the visual axis obscuration was comparable at 5 years. So yes, a little bit higher incidence of posterior synechia, but otherwise it was comparable. Complications. What stood out is that the rate at which ultimately at 5 years they both reached the same endpoint in terms of their visual acuity, but the pseudophakic group reached there much faster as compared to the aphakia, which had a slow climb. And I think in our population, who are going to give up on any therapy, any treatment, if they don't see a visible, tangible benefit, this is very, very important, that if you can give a faster rehabilitation, and without glasses, without contact lenses, at least partial visual input, then it is going to be a much more successful treatment. Now when we talk of primary IOL implantation in infants, I think this is what I do, and I recommend most of us should do, is if you can do like some of our experts, all of our experts sitting here will say that, oh, it's very easy to do a manual anterior posterior axis, do a vitrectomy and put an in the bag IOL. But in children below the age of 1 year, it's not always that predictable. So what I often do, particularly below 4 months of age, I perform a manual anterior capsular excis. I will put in an IOL in the bag, your choice of IOL, 3-piece or single piece, but hydrophobic acrylic would be without any commercial bias, my recommendation. And then go in with a 23 gauge vitrector and perform a capsulectomy vitrectomy. So therefore, at least you have that IOL in the bag. You don't have to worry about an inadequately sized posterior capsule opening. Another technique that we are finding more and more useful in many situations, but particularly in pediatric cataract surgery, even in infants, is that of optic capture. Now yes, this is skill dependent and takes a learning curve, but when we start in older children, 5 years, 6 years, then start coming down, perform a manual, or if you have access to a femtosecond, even better, femtosecond anterior and posterior capsular excis, and you can do an optic capture even through a femtorexis. Put in a 3-piece foldable lens in the capsular bag, and now as we can see here, the entire optic is being slid behind the posterior capsular excis margin. Now the advantage of optic capture is twofold. One, you don't need to do a vitrectomy because there is complete fusion of the capsules, and therefore your risk of visual axis obscuration is very, very minimal. But more importantly, also we realized now that it actually locks the IOL in its position. So once the IOL is captured, it's a noose around the optic haptic junction, and therefore it is not going to move. So in both ways it makes total sense to perform an optic capture. Again, a skill-based procedure, but worth learning. And we publish 1-year results, and we are almost ready with our 5-year results of the same study now, where we randomly did in the bag IOL or an optic capture. And in both groups, 50% of our children were below 1 year. This study was not just for infants. And until 36 months follow-up, we found that the optic capture group, there was no visual axis obscuration, even when we did not perform a vitrectomy. And remember that 50% of this population is below 1 year of age. So yes, it does delay or reduce visual axis obscuration. And in terms of glaucoma, again, VAO and glaucoma were completely comparable between the groups, so were the inflammatory deposits. So I think it can be achieved in most eyes, older obviously, but as you keep getting practice, even in younger eyes, and this is a technique we should learn. I was recently asked that why would you want to avoid vitrectomy? I think it's because it's an additional procedure. Not everyone has the machinery, not everyone has the expertise to perform a good anterior vitrectomy in every part of our country. So I think with that, the only thing I would like to say, infant or not infant, any small eye, corneal diameter, microphthalmos, or like I started my talk, if in your surgery something has gone wrong, if you have damaged the iris, traumatized the eye, please pack up and leave the child aphakic. We will be doing much more good than harm. Thank you.
I think Jagat Ram would appreciate your comments on IOL. Your guidelines to all us Indian colleagues will be very important. Would you, what are you doing yourself, and what would you recommend in general, very briefly?
I think I will recommend what Dr. Vaishali Abhaykuma said, that ideally speaking, we should put IOL implantation more than 6 months of age. Almost same thing what you are doing, but selectively I have also used in younger than 7 month age. 7 month age is the study which you quoted. So that is what I will say, that is the guidelines for everybody. Whereas selectively, if we are doing anything, that has to be proved by the scientific literature.
Thank you, sir.
Yes.
Do you take any special precautions to prevent vitreous prolapse when you do primary posterior capsular access? Because you said you avoid vitrectomy, and most of the times in my hands vitreous comes when I do a PVC. So do you take any special precautions to prevent vitreous loss in PVC?
So again, like you said, this is a very relevant question. That one, you are candid enough to accept that you rupture the vitreous more often than you think. So I think first thing is, in technique, what we do at all surgeons at our centers, we make a bent, a slanted cystotome, and we sort of swipe it up. We don't do a vertical puncture ever. So it's more upward puncture, and then we use microrhexis forceps to pull it up. And the other thing is that a lot of times we don't even know that we have ruptured the vitreous. So we must use preservative-free triamcinolone after doing a PCCC to confirm whether the phase has been ruptured or not. So yes, it's more of a detection problem. I think all of us do it. And prevention would be by using more heavy viscoelastics like Helon 5 or no financial interest. And some people also inject it through the opening once they do. But be very careful in the amount that you inject. Any comments from the panel?
I
Anybody?
think the additional to what was told is the focusing. You should be able to use both your hands, focusing crisp every second of the procedure. If your focusing is not good, and you really need a good microscope with a good glow, red illumination, you can generally avoid rupturing the capsule. But if you rupture, there is no shame in stopping there and then perform anterior vitrectomy and then continue capture. Capture can be done even after anterior vitrectomy because there are two main advantages, she told. One is the stability of the IOL and other is the visual axis obscuration. So vitrectomy we had to do it, so we did it, but at least the stability will be guaranteed with capture, unlike the in the bag, which is vulnerable to capsule contracting forces. So it doesn't matter if you rupture, don't worry about it. Be ready with anterior vitrectomy and still continue performing PCCC and capture it. But slowly, it's with the time and experience, it's not difficult.
The advantage of capture is you don't have to change the IOL power for the sulcus and bag.
No, no,
So-
we fix up the power accordingly only. We planned a capture. We initially aim capture, and therefore we have an appropriate power, half a diopter more, generally speaking.
How about starting the rupture with the capsule tear with forceps or instead of system?
You can, but with the puncturing with the forceps, it's not very sharp like a needle. So you have to do vertical thrust, which is lethal, which is bad. So you kind of swipe and take the capsule along with it, lift it up so that it is pulled up, and then it tears in that process. It stretches and pulls.
Hello, sir.
Yeah, I think you
sir-
decide the time and we'll.
I think we take this last question and then I would invite Jagatram sir to set up his laptop meanwhile.
That's level of anesthesia. Does level of anesthesia helps in at that particular point? We can tell the anesthetist. or-
Yes. I think.
Is there
but
any role? I mean, is there any
yes,
role?
there is if the deeper the plane of anesthesia, the better it is. And I think this goes for the entire surgery. Even when we are doing an INA, you don't want any bulges. So in general, when we are performing a surgery, we know that it's going to last, let's say, half an hour, 45 minutes. So we generally ask our anesthetist to put them deep prior to what we start. And we will tell them that, okay, we still have 15 minutes to go, so don't start lightening. You have to inject, please inject, but don't lighten the patient.